first case. It's one case, but it's a long case. It's 10 questions in a part of one question. So this is the case. As usual, when they give you a case, just don't rush. Step back to say, I know this. Figure out what the case is talking about. Make a diagnosis. Use the information in the case to answer the rest of the question. You should count yourself blessed if you get a case study rather than stand alone, because most of the information is there. You just have to go through the process of finding out what is wrong with this patient. And when you know it, it's easy. So what do we have? A 32-year-old G2P1. Just by that line alone, you know this is a GYN case. This is a maternity case. So they can't hide anything from you. I just told you. It's 32-year-old. It's G2P1. That means the patient is pregnant still, had one baby before, and is pregnant. So they cannot hide anything. You know, it's a maternity case. Bring your content related to maternity and figure out what kind of content you need to use to answer the question. Patient is attending a 38-week prenatal checkup. So this is a prenatal visit for prenatal checkup. She recently completed a 1-hour glucose tolerance test, and the results may indicate gestational diabetes. Is that giving you a clue? Yeah, that's what to keep on doing, asking yourself, this is a clue. 32-year-old came for a checkup. She has a test. She was worried that she may have a gestational diabetes. So that's why she's there. That's your chief complaint. That's all. That's all the case is about. The rest of the information is supposed to support what we have. Client expresses concern about managing blood sugar. She's worried about how can she take care of this sugar and how it's going to affect the body and the baby. Spend time, understand the case, don't rush. You know this is gestational diabetes question. She want to know how to manage it. I give you a vitals. Every patient that come to the emergency room, go to the hospital, need a vital. Temperature is normal. Blood pressure is look like she's hypertensive, 140 over 80. Heart rate 78. Respiratory rate is normal. SAT is that, right? Then she's pregnant, so we got to do exams. Don't be surprised. She's alert, cooperative, anxious about the diagnosis. What diagnosis? Gestational diabetes. A fetal heart rate tone is 150 beats per minute, right? Is it normal? The fundal height is above the umbilicus. She's 38 weeks. Is it normal? She has plus one leg edema. Is it normal? As you read, you're trying to work through the process and ask yourself, is this what I expected? She has no past medical history, right? She take prenatal vitamin and take labetalol. Is it because of her blood pressure? I don't know. And we get a lab. Hemoglobin A1C is 6.2 when she came in. A three-hour glucose tolerance test shows a 170 milligram per deciliter. Normal is 140. A urine, there's no protein there. This is a weight. A pre-pregnancy, before she became pregnant, a BMI is 21, right? And a weight was 130 pounds. Now she weighs 144 pounds. You've gone through the case. You know what is going on. You analyze it. You know what is normal, what is not normal. Don't freak out. Don't worry. Just have an idea what the case is about and know all the buzzwords. Somebody who is 38 weeks, 2 pregnancy, 1 living, had a test that shows that she may have gestational diabetes. She's worried she came in. You examine her. This is what you find. You did some lab work. A 3-hour glucose is 170. Hemoglobin A1C is 6.2. There's no protein. These are weights before and during the pregnancy, and this is a current weight. So at least you have an idea what is going on. I've given you information. Use it, and then use it to answer the question. So don't worry, I got you. So what is the question? The next review the clinical data. Which finding is concerning? Based on what you know from this case, which of this is concerning? Blood pressure of 140, fetal heart tone 150 beats per minute, 3-hour glucose tolerance test is 170. The fundal height is current weight of 144 pounds and a +1 in leg edema. What do you think is concerning? This is the umbilicus. Umbilicus is usually 20 centimeters, 20 weeks. Anything above 20 weeks will be above the umbilicus. So she's 38 weeks. She's 28 weeks. And I said it's above the umbilicus. So that's normal. So it's not a problem. Right. She has +1 leg edema. She's pregnant. That's not a problem. That's okay. Right. A glucose tolerance test, you can see that the normal is 140. And so this is 170. This is bad. This is not good. Fundal height. A fetal height tone, 150. Right? The fetal height tone is like 110 to 160. That's fine. 150 is okay. So the kid is doing fine. The blood pressure is 140/80. And you ask yourself, should I worry about it? Well, if you look at the case, this is the case. If you look at the case, 140/80, she's on labetalol. Probably she has hypertension. So I'm not worried about it. She take blood pressure medication and blood pressure is 140. So I'm not worried about it. But she's being treated for that. So we're taking care of it. The only thing that is worrisome is a 3-hour glucose tolerance test. The rest of the information is all expected, or there's nothing we can do right now. She's being treated for. A fetal heart is doing fine. A fundal height is in the right place. A current weight. What do you think now? A current weight. You have to know how to do this. If you don't know, when you listen to me the first time, check out that 10 class. I have free maternity videos. You have to know. This is very, very important. It's common things that your board can ask you. I don't know questions they can ask you, but something general everybody need to know before you can take the test. First trimester, everybody is supposed to gain between 1.1 to 4.4 pounds, right? No matter your weight, but depending on your pre-pregnancy weight, right? Right. This lady, she was at 21. So that is ideal body weight, right? So she's within normal range. So for her, she's going to gain 4.4 pounds the first trimester. The subsequent trimester, every week, she's going to gain 0.6 pounds. And you just calculate it. It's easy. So know the weight, pre-pregnancy weight. Know what you're going to gain. Everybody gain 1.1 to 4.4. And then after that, 0.6, depending on your weight. If you're obese, you're going to overweight, you're going to gain less. If you're underweight, if your BMI is less than 18, then you gain 1 pound every week after the first trimester. So after 12 weeks, she will be 14.4. Then she's 38 weeks, right? If you subtract this from it, this is like 16. 16 times 0.6 will give you something close to like 10-ish, right? So or 9-ish, right? In the end, she will end up gaining close to 14 pounds total. So then you add it to a pre-pregnancy weight, and that will tell you she's 30. So 144 is normal. This is the normal range. So this is all normal. It's expected fine. So you should be able to know how to calculate where she's supposed to be. So this is unexpected. The only thing that you need to worry about is the glucose, but know how to calculate their weight. And weight is fine. Client is diagnosed with gestational diabetes after 3-hour glucose test. Why? Because he was greater than 140. What is the next priority intervention after the results? So now she has gestational diabetes. What are you going to tell her? Right? Schedule a repeat glucose tolerance test, provide dietary counseling, and encourage regular blood glucose monitoring. Refer the client for an insulin pump consultation. Encourage increased calorie intake to meet pregnancy need. What would you do? Somebody has gestational diabetes. Think about each answer choice and see if it's fine. Why would you have to refer them to a pump, insulin pump? In medicine, when you have a diagnosis, medical problem, we always try to do it lifestyle modification. Always go with lifestyle modification first before medication. Even psychotic problem, we try to see if we can manage it. If you have stressful problem, you can manage it with that. So this is what is common, right? So we're not going to send you there, right? We're not going to increase your calorie either because you already have diabetes. I know you need some calorie for your pregnancy, but we got to make sure we don't cause too much. Your sugar is well controlled because it causes problem, right? The diagnosis of gestational diabetes is made after 3-hour test. The 3-hour test was positive. There's no need to repeat it anymore. So just by test taking strategy, you know that B is the right answer. So just provide some counseling and encourage the client how to monitor their blood glucose. And that's how you approach this question. So number 3. So you should expect this. This should be not be surprised. This case should not surprise you. You know she has gestational diabetes. We're teaching her. She's going to ask what complication is going to happen. Or you should know that your board will ask you what complications she's going to get from having that diagnosis. It should not be surprise to you at all, right? Which potential complications should the nurse monitor for in the client pregnancy due to the diagnosis? Is a content you need to know. That's why we don't want you to have diabetes when you're pregnant, because he has some side effect on you and on the kid. So what do you think? Is he going to be hyperthyroidism? Are we going to have Macrosomia baby? That means a big baby greater than 8 pounds, 14 ounces, or 4,000 grams of fetal shoulder dystocia, or oligohydramnia, or preeclampsia, or fetal heart defect. What do you need? What do you think? Because of the glucose increase, insulin increase, and so insulin will lead to deposition of fat. So you have high glucose, and then you have high insulin, and this will lead to fat deposition, and the baby get big. That's what happens. So that's what is going to happen, right? If the baby is big, it's not going to come out well. You get shoulder dystocia. So this is all is connected. You have a big baby, your mommy pelvis is too small. Baby is not going to come out easily. The shoulder can get caught up. It will become a problem, right? Think about it. If the baby is big, why would the amniotic fluid be small? A big uterus. If I have a big baby, then there's going to be big fluid around there. So you get poly hydramnion. So the amniotic fluid is going to get bigger, right? There's more likely to get preeclampsia because you get edema, your blood pressure go up, you get fluid overloaded, and then it affects the rest of the kidney. And therefore, preeclampsia is also common. It's all related, right? There's no hyperthyroidism, right? Hyperthyroidism increases metabolism, so the baby mommy is not going to be, is unrelated to that. Watch for this fetal heart defect. Okay, fetal heart defect happen when the mommy has pre-diabetes. So see, they have pre-gestational. We call it there's something we call gestational diabetes. So we have gestational diabetes, right? And we have pre-gestational diabetes. This means you have diabetes before you get pregnant. Women who have diabetes before they get pregnant, they're more likely to have a baby with a fetal heart defect. This mother was not diabetic before she get pregnant. She was diabetic after pregnancy. That's why we call it gestational diabetes. Therefore, there is no fetal heart defect, but you can get preeclampsia, we can get shoulder dystocia, and we have this. These are the 3 common side effects you should expect. Okay, so this is the content, and you should have polyandramnions, right? is an appropriateness action to manage the client gestational diabetes? So how is the appropriate action? What is the best way to manage the diabetes? Advise the client to exercise daily, avoid exercise during pregnancy to prevent hypoglycemia. So you want to tell her not to exercise. Teach the client to monitor a blood glucose 1 to 2 hours after meal. Encourage the client to eliminate all carbohydrate from the diet. Recommend increasing client prenatal vitamins to manage a blood glucose. This is just a straightforward question. I just want to text you, give you a bonus, right? This is straightforward. You know some of the answers, does not make sense. We don't use prenatal vitamin to manage your sugar. So D is completely gone, right? So what do you think about A, B, C, right? Right. We all need carbohydrates. So you cannot eliminate all carbohydrates from your diet. Diabetic patients cannot eliminate all carbohydrates from their diet. They stay on low carbohydrate diet, but they still get some carbohydrate. You still need some sugar, right? Watch for these kind of all or nothing, right? Or just by say or make the answer choice negative wrong. So the only thing that is good is monitoring your blood glucose after a meal. So that is the most appropriate teaching you provided. The client returned 1 week follow-up due to uncontrolled home glucose level. The healthcare provider prescribed Lispro. The nurse has provided teaching about the new medication. Which of the following statement by the client at discharge indicate ineffective teaching? So don't answer the question. Go back to the question being asked and break it down. Blood glucose was no control. I've been prescribed insulin, Lispro, right? You have to know what it is. This is like fast acting. It's react really fast. The nurse provided teaching. Which of these information by the patient indicates teaching is ineffective? That means they're saying something that is wrong. So after you prescribe them Lispro and you teach them how to use the medication, which one is wrong? I will monitor for shaking, sweating, and anger each day. I will drink 4 ounces orange juice, chew one hard candy if I start shaking or sweating. I will eat within 15 to 30 minutes after taking the injection. I will inject the insulin in the muscle of my thigh. I will avoid all carbohydrate in my diet to control my sugar. I will take the medication at bedtime. What is this question asking? Content related to this medication and content related to management of diabetes, which I know you know. So what are you going to do? It's a selected apply. You don't have to pick everything. Pick those that you're confident. So which one do you think is appropriate? This is a fast acting. You got to take it with food, right? As soon as you eat it, you take it, you have to eat right away because its onset action is very short, 15 to 20 minutes. So taking it at bedtime will make you really sick. If you take it, you have to eat. So this is good. I will eat within 15 to 20 minutes. That's when it's going to start acting. So that's why it's the right answer, right? You don't inject insulin in your muscle. It's going to cause problem. Bad problem. Okay. So don't do that. It's injected subcutaneously. Okay. You cannot avoid all carbohydrate, like I told you. You have to use low carbohydrate. So D and E R and F is wrong. Yes, if you become, this is acting and talking about hypoglycemia. When you're hypoglycemic, you got to try to get 15 grams of glucose. 15 grams of glucose, you can get it from 4 ounces of orange juice. You can get it from chewing one hard candy. You can also get it from 1 cup of raisin. You have to know at least 3 of this, right? That's where you can get it from. So those are the little things you have to know. You can even use 8 ounces of low-fat milk will give you 15 grams of glucose. So know this information, how to get 15 grams of glucose. And then I will monitor for shaking, sweating, and anger. This is hypoglycemia. So which one need intervention? This is right. Monitor for hypoglycemic symptoms. Okay. Get 15 grams of glucose, which is 4 ounces of oranges or 1 hard candy or 1 cup of raisin or 8 ounces of low-fat milk. And then eat within 15 to 30 minutes because that's the onset of the medication. And you shouldn't inject glucose in your diet. You cannot eliminate all carbohydrates in your diet. And then you have to take the medication with food at least 15 to 30 minutes. So that's the one you should intervene. Okay. Now, this is the patient now. At 36 weeks, 37, you remember she's 28, now she's 37 weeks. The client was admitted for labor induction. Now she's in labor. During the second stage of labor, the nurse noticed that after birth of the fetal head, there is a retraction of the head towards the maternal perineum. Read it again and understand it. Don't answer the question without understanding what is being asked. Of course, you can skip it and just guess the answers. But this is your answer right there. She's 37 weeks. She came in for induction of labor because we worry about Macrosomia, right? She's in the second stage. The head of the baby was delivered. Then the nurse saw that it retracted towards the perineum. What is the diagnosis? What do you think is going on with the baby? What would the nurse know? Can you identify what is going on? Can you figure out what is this? Yeah, that's the case right now. So which of the following action the nurse should take? Select or apply. So you know, based on this, that is, when the baby head is delivered, it retracted towards the abdomen, towards the maternal perineum. What do you think is going on? You know the diagnosis. First, you make the diagnosis. Then second, you figure out what you need to do. Apply fundal pressure, perform Leopard maneuver, apply suprapubic pressure with maternal thigh flex to the abdomen, place the client in the left lateral position, and document the timing of the finding. First, what do you think is going on first? Guys, what do you think? What is this? What am I telling you? Make the diagnosis. If you make the diagnosis, it's easy. So what is this? Can you recognize it? Do you know what it is? So if you know, you can put it in the chat. But what is this diagnosis? What do you think? What is the diagnosis? So if you give me the diagnosis, or if you don't, you can just use it to answer the question. First, you have to know what diagnosis it is, and then you can figure out. But you can also select or apply. So, but if you select too much, you lose points. So you pick those you're confident. But the easy way to make this easy is to make the diagnosis based on the picture that I've shown you about the head retracting as soon as it's born. And this is what we call shoulder dystocia. Baby head is stuck. When it get delivered, it's retract back. That's the total sign. It's called the total sign. Therefore, how do you manage it? How do you manage the total sign? Every time you see shoulder dystocia, they're going to give you this. Fundal pressure. Don't pick it. It's wrong answer. Leopard maneuver. You have to know what leopard is. Leopard is used to find the fetal position to figure out whether the kid is breech or not and rotate the baby or listen to the fetal heart. You know exactly where it is located. The baby already in the second stage of labor. There's no way you can reposition the baby, and we already delivered the head already, so there's no way. So that's not possible. Placing the patient in the left lateral position is not going to help them. The most important is document the time because you're going to run out of time. Time is a factor. If after 5 minutes the baby is not delivered, we have a problem. Baby will have brain injury. The treatment for shoulder dystocia is something we call McRoberts maneuver, and that is suprapubic pressure, not fundal pressure. And then while you're doing that, you flex the mommy leg to the abdomen. That is McRoberts. So is it selected apply? This is a little bit hard question you have to know. So you do this and you document the finding. And you start counting. 5 minutes. Baby, we got to deliver you. If you have to do episiotomy to bring the baby out, you got to do that. You have to call everybody so that we can get the baby out before the baby become anoxic brain injury, develop anoxic brain injury. So when you see these questions, so that you start here, don't pick fundal pressure. It's going to be there. Pick McRoberts, or this is the description of McRoberts. I just want to give you all content related to maternal gestational diabetes. If they give you, these are the things they will ask you because it's clinical. What should the nurse suspect? This is it. The client was delivered at 9 pounds. Just by that, you should know this is a macrosomia. It's greater than 8 pounds and 4 ounces. So that's the definition of or greater than 4,000 grams after McRoberts maneuver, right? The next assessment shows what? Crepitus over the left arm and Monroe reflex is gone, right? There's no Monroe reflex. So if this is the baby, right, and this is the left arm, there's crepitus here. That means you can hear sound when you push on it. And when you drop the baby cannot lift that leg and the extremities up. So there's no Monroe reflex on that. Does that give you something? It's a big baby, 9 pounds. Therefore, what do you think? What should the nurse suspect? Is he a head injury? That is why the baby is behaving this way? Is he a humerus fracture? Is he a chest injury or hypoglycemia? These are content related. So what do you think? Baby has crepitus over the left extremities. And then when you drop the baby, there's no Monroe reflex on the left. And the baby is 9 pounds. So what do you think? Think about it. Do we think the baby has injured itself in the head? Or while they were pulling the baby, they injured the baby head? Or you think they fractured the humerus? Or you think there's an injury to the chest? Or this is hypoglycemia? Think about it. I give you physical finding related to that. How is the baby going to do Monroe? That is the key. If you know how the baby will behave in the Monroe, you got to lift your extremities up. It has nothing to do with your brain. So it's not a head injury. It has nothing to do with having sugar available. It's because there's fracture in his upper extremities. That's why the baby cannot raise his hand. So I'm digging deeper. A nurse is reviewing the clinical client chart and noted uncontrolled blood glucose throughout the pregnancy. So the mommy blood glucose was uncontrolled. Which finding the nurse should expect in the newborn? It's the same question I'm asking here, but different way of asking. We know mommy has gestational diabetes and a sugar was uncontrolled. After baby is born, what do you expect in the baby? Do you see the baby will be yawning and will have high pitch cry, or the hematocrit will be elevated, or the baby will have imperforated hands, or they have projectile vomiting? It's the same thing, right? What do you think? Finding that is related when you have gestational diabetes, what will happen to the baby? Are they will be yawning and will have high pitch cry, or the hematocrit will be elevated, or they will have imperforated anus and projectile vomit? What do you think? These are all content you have to know about gestational diabetes. What do you think? Yawning, high pitch cry, elevated. Hematocrit is going to be imperforated anus or projectile vomit. Which one will you see in that patient who was born by a mother, right? By a mother that blood glucose was uncontrolled. What do you think? Sometimes the NCLEX will do this. It will give you bad stuff, but it does not answer the question. Yawning, high pitch cry is neonatal absent syndrome. It's common because the baby is withdrawing. You don't withdraw from a mother born. Baby doesn't withdraw when born to a mother who has gestational diabetes. The only thing they will show is hypoglycemia, right? Yawning and high pitch cry is not hypoglycemic symptoms, right? So don't fall for it. I intentionally put it there. But these are all withdrawal symptoms related to opiates. So neonatal absent syndrome. So this is it. Projectile vomiting, of course, this is not edge prone. Hey, no, imperforated anus is not edge prone related, or the projectile vomiting is not pyloric stenosis, right? This is imperforated anus and edge prone are always sometimes related, but most of the edge prone is due to lack of relaxation of the internal sphincters. Imperforated anus, they are congenital problem. There's no opening for the anus to be out, so the baby cannot pass meconium. So that does not apply. This is what happened. Hematocrit, right? When you have gestational diabetes, there is a placenta insufficiency. This is why they have preeclampsia, right? Placenta insufficiency. So the baby is not getting enough oxygen. As the process is going to increase RBC, and the baby will develop polycythemia vera. Watch for this. Kids born to mother with gestational diabetes will develop polycythemia vera, and this is what we have here. That's the content. Elevated hematocrit. If you don't know it, this is it. Straightforward here. So don't pick this because I put it there. It's just a trap. Don't pick it. So gestational diabetes can lead to polycythemia vera. That means hematocrit elevated in the newborn. Which additional action the nurse should what? Take for the newborn. So we know these are the things we've seen. What else do you think the nurse should do? Assess for brachial plexus injury because the baby is big. He had shoulder dystocia. We pull it out. We have clavicle humerus injury. Now he has polycythemia vera. What other assessment should the nurse do? Check for brachial plexus injury. Check for clavicle injury. Check for cephalohematoma. Monitor capillary blood glucose frequently. And what? Encourage the client to breastfeed the newborn every 2 hours. Right? It's something you should know. So what do you think? What do you think the nurse should do? Well, they should encourage the mother to what? Feed the baby every 2 hours, right? If we have humerus injury, well, you should check for this. We should check for clavicle injury, right? If your clavicle is going to be injured, your head, hematoma, as we try to push you out, you can develop cephalohematoma. This is hematoma that has not passed through suture line. These are all traumatic birth. You should know, like it's a traumatic birth when you have shoulder dystocia. So all these things make sense. And baby was born by a mother who has what? Gestational diabetes. Well, we should monitor their glucose frequently, right? And then we should check for brachial plexus injury. So those are all indicated. These are all indicated checking for brachial plexus injury. And the last question is a bonus question, but it's a test taking strategy. A heel stick capillary glucose from the newborn show blood glucose of 39, 5 hours after birth. So you check the baby glucose is 39. It's 5 hours after birth. What would you want to do? Administer oral glucose to the baby, give them IV glucose, administer baby formula to the baby, notify the air care provider. The test-taking strategy is a content-based. Don't fall for it. NCLEX will trap you with that. What do you want to do? Baby glucose is not 39. 5 hours is being born. What do you want to do? Give them glucose, oral glucose, IV glucose, or give them a formula or call the doctor. What do you want to do? Last question. Give me the answer and let's call it. And then we summarize the case. It's a straightforward gestational diabetes. So what do you want to do? What do you think? Administer oral glucose to the baby. Administer IV glucose to the baby. Administer baby formula to the baby. Notify the air care provider immediately. What do you want to do? Think about it. Straightforward. Think about it. And you will see this in adults, even if this is a neonate and then this is the gestational diabetes. Always think about it. This is hypoglycemia because it's less than 40 in the neonate, right? In the newborn, 40 to 45. Anything less than 40 to 45 is hypoglycemia, right? But if you look at the question, there's nothing in the question telling you baby is sick. The baby is not sick. He has no symptoms. So hypoglycemia management is based on symptoms. If you have symptoms, I cannot use your nothing by mouth. Oral is gone. So I have to give you IV glucose or IM glucose. If you have no symptoms, that means no complaint, then I got to use your mouth. The baby mouth will work. Therefore, we're going to use the mouth. But if you're going to use the mouth, you're not going to use glucose to feed the baby. So we should not give the baby oral glucose. Just give them formula and they will be fine. So watch for that. Feed the baby will be good. But this is the case. The mommy is a summary, is a 32-year-old. She's 38 weeks pregnant. She came in because she did a test, shows 1 hour. She may have gestational diabetes. She's worried about it. The fundal height was normal. This is a 33-hour glucose tolerance test and a weight before pregnancy and weight after pregnancy. Like I said, you need to know how to calculate whether this weight is consistent. Like I said, a BMI of 21, if your BMI is 21, you're going to gain maximum 4.4 pounds in 12 weeks. And subsequently, every week, you're going to get 6 pounds. And so for 28 weeks, she has 60 more pounds, 16 more weeks. You just multiply 0.6 to 16. That will give you the actual amount. Then you add it to the 4.4. That will give you total. So I think you'll give you like 10 pounds. So she's going to gain at least 14 pounds throughout up to 28 weeks. If you add it to 14 to this, that will be 144. So her weight is normal. That is the case. And we went through the process, how to go through what they're going to ask you, McRoberts, shoulder dystocia, side effect of gestational diabetes. Take care of yourself and thank you for watching. Good luck. Welcome to Adapting Place. Bye.